Hi, everyone. Thank you for joining our live Winona Q&A session. My name is Liv Gruber, and I help out with the design at Winona, but today I'm going to be your moderator. So today we have our Chief Medical Officer, Dr. Michael Green. He's going to be answering all of the questions that you might have. So go ahead, you can start putting your questions in the chat right now, and he will answer those after he does his introduction. So, Dr. Green, do you want to give your intro?
Sure. Hi, my name's Mike Green. I'm an OBGYN, I'm an MD. And I actually did a family practice residency first and fell in love with delivering babies and women's health. And so I did a whole second residency in OBGYN, and I've pretty much been doing OBGYN. I got out of residency, my OB residency in 99. So that's 23 years now. I love what we're doing with Winona. It's really exciting to be able to reach people in this way that, for one reason or another, either don't have access to, or their physician doesn't want to prescribe HRT, or it's just easier for them. And so it's a really nice project, and it's really good thing, I think, to be able to reach people like we do with Winona. Hormone replacement therapy has a lot of misinformation out there. Like most things in medicine, Dr. Google is usually wrong. And so hopefully today we can answer your questions, clear up some of the myths that are out there. And even some of us physicians are a little bit behind the times on some of the latest research. And since this is sort of what we do for a living, I have to keep up. Not that it's a have to, but so I try to stay really current with what's going on, so that I can provide the safest and the best treatment for you to relieve the symptoms. So that's sort of the concept. We really want to answer your questions. That's what we're here for. I'm going to start off with an opener question. It's funny. I've been doing this for a while, and it seems like things come in spurts. All of a sudden it's like, man, I got like 4 questions this week on this thing, and all of a sudden the next week I'm getting questions on something else. And so it seems like sort of the question of the day or the question of the week has been about acne. Not really sure why. It's just the way, it is. All of a sudden I'm getting a bunch of questions about acne. So I thought I'd talk about that, about menopause, perimenopause, hormone replacement therapy, and acne, and how that all plays together. And for a lot of women, maybe they had acne, when they were going through puberty, and then their skin was fine, and then all of a sudden now they're breaking out again. Or they weren't even breaking out again, and then they start hormone replacement therapy and they start to have acne. So what's up with that? And why is that happening? And how can we fix it? So there's sort of 3 categories in my mind. The first are women that get acne because of their menopause or perimenopausal status. And so maybe, you haven't had acne, maybe now and then you have a pimple here and there, but you really haven't had a problem. And then all of a sudden you notice, as you're getting your other perimenopausal symptoms, acne becomes one of those symptoms. That's actually pretty common. And the thing is that the skin is an organ, like your heart or your liver or your lungs. And it's actually the biggest organ in the body. And it's very complicated. There are people that's all they do is skin, dermatologists, for instance. So it's a complicated organ, the skin is, and it's very active and it's very sensitive, and it has a lot of receptors, has a lot of sensitivity to the various hormones, and particularly estrogen, but also progesterone and testosterone. And so one of the things about the time around menopause, this menopause transition, is not just that the hormone levels start decreasing. They don't decrease in a nice, smooth, steady fashion. If they did, things would be a lot better, honestly. They kind of come in spits and up and down. And so the ovary is producing less hormone, and then it sort of spits out a bunch of hormone all at once, and then it kind of goes dormant again. And it's almost like the dying gas of the ovary trying to get this hormone out. And these rapid changes in hormone levels can be really disruptive in the body. And the thinking is that's a big part of why women start getting acne again during the menopause transition. It's sort of similar to puberty. So in puberty, there's this huge transition of all of a sudden these increased hormones, and again, not, completely nice and steady, but in sort of spurts. And so people get acne then. A lot of women experience acne around their periods, and it's really for the same reason, because hormone levels change abruptly. And so we see that. It's one of the reasons people get hot flashes, is these abrupt changes in hormone levels. And so these abrupt acute changes in the perimenopause period and the menopause transition can cause acne, because you get this disruption of this, what the skin is used to, of this nice easy flow of hormone, this nice normal state, and all of a sudden it's all different, and that can make the skin break out. The treatment for that type of acne is hormone replacement therapy, because what it does is not only does it bring the hormones back to where they're supposed to be in the youthful levels, but it keeps them at a nice, relatively stable level, where that's what it's designed to do anyway. And so now, instead of having these spikes of hormone, you have this nice steady hormone level, and that helps the glands in the skin so that they don't produce acne. And so hormone replacement therapy can be a good treatment for acne. So that's sort of category 1. Category 2, some women will find when they first start the hormone replacement therapy, or when they make a change in their dose, all of a sudden they get acne. So maybe they weren't getting it from the menopause transition, they were doing fine, and all of a sudden, they start one of our hormone creams or pills, and next thing you know, oh my gosh, I'm breaking out, and that's annoying. And I totally understand why, I wouldn't like that either. And that's, again, it's from an abrupt change in the hormone level. So you're cruising down at this low hormone level that's giving you side effects, giving you symptoms. We're bringing that hormone level back up to relieve those symptoms. But in that transition state where we're first starting your HRT, or if we have to increase or decrease the dose, so there's this rapid change in dosage, that can again stimulate the glands and cause acne. That should go away relatively quickly. So it takes a little while for the body to adjust to the new hormone levels, but once the body adjusts, it tends to level out and that acne goes away. One of the frustrating things from my end, and I'm sure from your end as well, is that side effects tend to come up very quickly when you start a new medication, particularly with HRT. The benefits can take a while to come along. So you start this new medicine, all of a sudden you're getting breakouts or some other side effect. It's frustrating because you aren't feeling the benefit. If you can stay the course and work through that and keep on the medicine, eventually those side effects go away, and then you start reaping the benefits and you start feeling much better. So it's easy to say, it's hard to do, but if you can push through, that acne side effect, it almost always goes away fairly quickly, and then you're on a nice stable dose again, and it should help actually prevent acne. So that's number 2. Number 3 is a little more rare, but it does happen from time to time. And that is women that are on hormone replacement therapy for a while now. They haven't changed their dose. They haven't been missing dosages. They're on a nice stable HRT, and all of a sudden they start getting breakouts. And that's really a different thing. And honestly, it's a little less understood, but this is the way I wrap my brain around it. In the menopausal state, the skin becomes very thin, the glands become inactive, and it's almost like sort of this dying organ that's not active anymore. The collagen decreases, the skin sags, you get wrinkles, it's thin, it looks sort of dry and old, and that's one of the reasons that people sort of age very quickly, as far as appearance, sometimes during this menopause transition. One of the real big benefits of HRT is that it improves the skin and it gets that skin looking young and healthy again. To be honest, I think that's my wife's favorite part of our hormone cream, is she really loves the way it makes her skin look. And it does it. It increases the collagen, thickens the skin, gives it that nice, healthy sort of glow about it. It helps smooth out the wrinkles because you have more collagen. But part of that increased health of the skin is that some of the glands become healthy again. So the sebaceous glands and the other glands in the skin, that were sort of old and dried out, are now healthy again. And those glands can get plugged and produce acne. So I think that's why some women get acne, even being on hormone replacement therapy for a long time. So it's sort of, that's sort of the downside of having, young, healthy skin, is young, healthy skin sometimes gets acne. And so you can treat that acne the way you would treat acne in other situations. Tretinoin cream, see a dermatologist, or the doctor to get that, or, the other over-the-counter acne medications can help with that. But that's sort of a trade-off of having young, healthy skin. Not for everybody, and I'd say really the minority. Most people don't get this, but occasionally people do, and it's annoying, but it's sort of a trade-off that you end up having to decide if that's what you want. So those are sort of the 3 categories, the way I think of it in my head, of why acne comes about in the perimenopause and menopause transition, and all really for different reasons. But I hope that helps. And if someone has follow-up questions about that, I'm happy to answer them.
Okay, I'm going to go ahead and read some of the patient questions, and we can come back to Ashley's if we have time, but we want to get your guys' live. So Allison asked, I read online that you shouldn't take DHEA with estrogen or testosterone. Please discuss why this is not recommended. Thank you.
Great question. So DHEA breaks down into estrogen and testosterone. That's really why we're using it. And it breaks down within 30 minutes. So when you take a DHEA capsule, that capsule gets broken down into estrogen and testosterone, and that's actually what's active in your body. So just as an aside, sometimes people get confused about this. Even doctors get confused about this because you would think, gee, if I'm taking DHEA, it might change my DHEA levels. And people have said, hey, I did a blood test and my DHEA levels are high. Should I still take this? And the answer is this isn't going to change your blood DHEA levels because before it gets there, it's already turned into estrogen and testosterone. So you have to understand that to understand the answer to the question. So here's the problem. Let's say that I'm giving you estrogen and I've dosed it to what you need for your situation. And then I don't know it, but you're also taking a bunch of DHEA. Well, because that DHEA gets broken down into estrogen and testosterone, it can drive your estrogen levels too high and ultimately cause a problem. Same thing with testosterone. So really the reason that we use DHEA is because it does a really nice job of getting testosterone into normal levels. But at the dose that I prescribe, it's not going to push it outside of normal levels. We're not using it for you to win a weightlifting competition. It can be used that way, and there are people that do that, but not in the dose that we give it. So in the dose we give it, it really just brings your testosterone levels back to the normal youthful levels. And so that's kind of hunky-dory. The problem is if you're also taking testosterone and the person that's giving you the testosterone doesn't know about the DHEA and the person that's giving you the DHEA doesn't know they're taking testosterone, it can drive those levels too high and cause problems and side effects. When I give you DHEA and I'm also giving you estrogen, I'm taking the DHEA into account when I'm calculating your estrogen dose to make sure that we don't push it too high. So it's one of those things where, well, what you're reading on the internet is true, but, okay. So it definitely can be unsafe if whoever's dosing the DHEA and whoever's dosing the estrogen and testosterone don't know about the other one. But because I'm dosing them together, I'm sort of putting it in a way that they work together and stay safe and effective. So in the situation that we're using the DHEA, it's safe to use with estrogen and testosterone. I hope that answers that question.
Okay, our next question is from Angela. I hear DHEA can cause hair loss. Is there anything we can do to prevent this?
So DHEA in really high doses definitely can cause hair loss. Again, it's the testosterone side effect of pushing the DHEA too much. I have friends in the gym that use DHEA as part of their whole testosterone. You know, there's some friends of mine, big guys in the gym that do testosterone for weightlifting and stuff. And part of that is a DHEA cycle with really massive doses of DHEA. In those doses, absolutely, you're going to get what's called androgenic side effects, which means testosterone-like side effects. And hair loss is definitely one of those. Acne is a big one, and other problems too. And so, you know, it's for what we're trying to accomplish, that's not the way to go. I'm prescribing DHEA in 25, maybe 50 milligram dosages. In that dose, it really should not cause the androgenic side effects, hair loss, and the other testosterone-like side effects. That's one of the nice things, again, about DHEA, rather than using testosterone, is just in the 25, 50 milligram dose, we don't really have to worry about those side effects like hair loss and the other things that we talked about. So it really shouldn't do that for you. And in fact, hormone replacement therapy in general should improve the quality of your hair, should make it thicker, should make it look better. Hair loss is complicated, and most hair loss actually is not from the menopause transition, but if it is, the HRT can help prevent that as well, besides just making the hair healthier, thicker, and looking better.
Okay. Leslie asked about the ingredients of the cream, but it looks like Ashley answered that. The next question is from Jan. Since starting HRT, I have had more regular periods I was only maybe having one every 6 months or so, really phasing out. Now in the last 4 months since starting HRT, I have had 3. Is there anything I can do? I'm ready to stop, LOL.
Yeah, I hear it. Yeah, periods are obnoxious. I mean, no offense, but that's one of the things I lucked out. I don't have to have periods. I tease my wife, it's like, aren't you going to give up your periods yet? So I get it. And it's sort of the same answer of the acne thing, because HRT brings you back sort of almost in time and makes you more youthful. It can start periods again. Now, if you're having normal regular periods on HRT, that's not dangerous. It's annoying, but it's not dangerous. If you're having irregular bleeding, that's a whole different thing, and that needs to be looked at. So if you're spotting all the time, or you're having these like tremendous periods that you don't usually get, or you're getting 2 periods a month consistently, that's not something that we want to just sort of blame on the HRT. Occasionally, there can be an underlying problem, but because your circulating hormones are so low, you may not notice that problem. And sometimes HRT can uncover that problem, and the way it shows up is with bleeding. So if you're having consistent bleeding or abnormal bleeding or irregular bleeding, you really need to be evaluated by your local doctor. You may need an ultrasound, you may need what's called an endometrial biopsy to make sure that everything's okay. If it's just that, oh man, I'm having regular periods again, and these are normal, like my regular periods, that's probably not dangerous. It's just sort of annoying. And unfortunately, there isn't really a good way to stop that. It becomes one of those trade-offs. I wouldn't really call it a side effect, but you could call it that. It's just sort of rejuvenating your body and getting it back to normal function. Now, for most women, that doesn't happen indefinitely, and eventually the periods will stop even on HRT, and that's for most people a good thing. Every now and then, I've had a couple patients that are upset that it stopped their period. And that's fine too. We all have our different things that we bring to the table, but there isn't really a way to quote fix that. It's sort of part of what comes with the package, so to speak.
Pesky periods. Going down the list. Dawn asked, what are the benefits of HRT for women in surgical menopause?
So surgical menopause means that you've had your ovaries removed surgically. And it's a tough one for people because, naturally the ovaries sort of shut down. They don't shut down overnight. It's gradual over maybe 7-10 years. And it can still be quite bothersome, but it's not like one day you're at one hormone level and the next day they're gone. And with surgical menopause, it pretty much shuts off the hormones overnight. And that can be really challenging. The symptoms tend to be much more severe. And depending on what age you are, typically that happens a lot earlier than it would if you were to go through normal menopause. And so the risks of being deficient in estrogen are magnified, because not only is the estrogen level dumping very quickly, going very low very quickly, but it's doing it at a much earlier age. And so the detrimental effects on your body of not having enough estrogen are starting much earlier. And so you can elapse a lot of time and sort of age your body with not having the estrogen really before you're the age that should happen. So HRT for somebody that's underwent surgical menopause is really actually very important. Number one, most people are pretty miserable because again, it's like a shutoff valve and it's just all at once. But probably even more importantly, behind the scenes, your cardiovascular risks are going up, your risk of osteoporosis, all these things that are important to have estrogen around for that keep you healthy are now starting to sort of snowball and go downhill. Estrogen replacement can reverse that. So we know that if women start hormone replacement therapy early, that they're less likely to have cardiovascular problems than women that aren't on HRT at all. Generally, that number is 60, but for someone in surgical menopause, it's actually going to be earlier than that. You really want to get on your HRT early. So it's really important for someone who's been in surgical menopause to get on HRT. And unfortunately, those women tend to need a much higher dose than women that go through natural menopause, because again, it's such an abrupt change. So in general, the dosage on that is going to be higher. So I usually start at a higher dose and generally work up a little more aggressively in those women, knowing that they're probably going to need more hormone to get their symptoms under control. But in particular, for somebody that's had their ovaries removed, that's had surgical menopause, HRT is really beneficial and highly recommended.
Yeah. My boyfriend's mom just went through surgical menopause, and she said she had a lot of anxiety as well afterwards.
Yeah, the lack of hormones, I mean, it really affects every part of your body. And anxiety is actually a very common symptom in the menopause transition. A lot of people think, most of us, I know me, we live in denial, and we feel something, oh, it's nothing. But, or we just sort of blame it on, well, I'm anxious because, my kids are teenagers or what have you. But there's a real physical effect of the estrogen on the brain that can really change the way the brain functions. And anxiety is a very common symptom of the menopause transition and of low estrogen levels.
Yeah. Okay, next question is from Shannon. I am into my second bottle of cream and starting to feel the benefits are not as great as they were the first couple of months. Should I look into increasing my dose? My night sweats have started again.
So yeah, that's going to be a situation where we're probably going to end up having to increase the dose. And there's a couple of reasons for that. One is that the body sort of accommodates to the dose, and sometimes you need a little bit more to get you there after you've been on it for a while. That tends not to continue sort of indefinitely. It's not like more and more and more and more. Okay, but there is sort of this thing at the beginning where you're new to this medicine, it works better. And then as you've been on it for a while, you may need a little bit more to get the same benefit. The second thing that may be happening is that, naturally the ovaries contribute some of the hormones that we're adding back. And over time, the ovaries contribute less and less. And so it may be that the contribution from the ovary is less than it was, although in 2 months, probably it's more that you're getting used to the medicine. But we do see this sometimes over longer periods of time, where it's really just sort of the natural process of the ovaries decreasing their estrogen output. And so we have to give you more back to make up for the fact that the ovaries aren't contributing. In your case, in 2 months, it's probably that your body is sort of accommodated to this hormone level, and you're going to need a little bit more to sort of push you through that. It's common in a lot of medications we use, and we have a name for it, of being naive to the medication. So we know that when we start on a medication on someone that's never had it before, they typically need less than somebody that's been on that medicine before. And the medical name for that is naive to the medicine. And so at first you don't need so much, and then over time, sometimes the requirement will go up. And so that's one of the reasons that it's really important to message me and we keep in communication, because hormone therapy is really dose based on symptoms. And so, I have an algorithm that works pretty well to get an initial dose, and that most of the time works pretty okay. But then sometimes we need to increase the dose over time, or I undershoot or overshoot, and we need to either decrease it or increase it depending on your symptoms. And so communication with me back and forth is important, and we'll get you to that right dose to get you feeling your best.
So Angela asked, you kind of answered this. Shouldn't the dose be based on an individual and their needs, that you're adjusting it based on their symptoms?
Sorry, say that again.
So her question was, shouldn't the dose be based on an individual and their needs?
100%. Absolutely. And that's why we ask, some of the questions we ask most of the questions we ask, honestly, are to make sure it's safe. But then a lot of the questions we ask are to help me figure out what's the right dose to start you on. And then communication back and forth, see how your body is reacting to this, and then adjusting the dose up or down as needed to get you where you want to be. This is not a one size fits all. It doesn't work that way. That's the way we do most medicines, honestly. The doctor kind of assesses the situation, starts with a dose that they think is going to be a reasonable dose, sees you back, asks how you're doing, and then adjust the dose as needed. So for example, I'm back on high blood pressure medicine, which is why I was just in the gym before this, okay? But that's the way it works. So my doctor gave me medicine that he thought would be appropriate. I'm following my symptoms, which in this case is my blood pressure, and he's going to adjust that blood pressure medicine based on how it works for my symptoms until we get my symptoms under control. In this case, it's high blood pressure. He's not going to do blood tests for the medicines that he's prescribing. He's going to follow my symptoms and adjust it appropriately. And that's exactly what we do with hormone replacement therapy. I assess your symptoms. I assess, what's your past medical history? Do you have your ovaries still? Do you have your uterus still? Your BMI? I take all these things into account, choose an appropriate dose. What I think is going to be, I usually try to shoot on the lower side of what I think is going to work, because my philosophy is that the least medicine required to get you feeling where you need to be is what we want to use. And so it's not uncommon that we need to up that dose a little bit as time goes on, because I'd rather undershoot than overshoot. Occasionally I overshoot, and there's some ways to check that by how you're feeling, and we have to drop down a little bit. But most of the time I stay on the lower side, and sometimes we have to inch it up a bit until we've got you feeling great. And so it is a very individualized approach. It's really not a one size fits all. It just doesn't work well that way.
Okay, so the next question is from Lori. I have been taking HRT in the form of Troche's wax. I don't know if I mispronounced that. I am tired of taking it this way. What are the benefits to creams, pills, etc., compared to Troche's?
So the big picture is we need a way to get the medicine into your body. And as long as whatever we're using gets the medicine into your body, it should work. So then the next step is really, it comes down to sort of personal preference and, what works for you and your lifestyle and what doesn't work so well for you. There is some theoretical advantage to the transdermal approach, that is giving the medicine through your skin rather than having you swallow the medicine. When you swallow the medicine like a pill, the medicine gets absorbed in the gastrointestinal tract, the stomach and the intestines, and most of that medicine travels first to the liver and then goes into circulation. And that's called first pass metabolism, because it passes through the liver first. When medicine absorbs through the skin, it goes into the general circulation. It will eventually filter through the liver, but it's not a big giant bolus of medicine, boom, straight to the liver. And so it's easier, the medicines get broken down by the liver. And so it's easier on the liver if you have it transdermally. So anybody who has any kind of liver issues, gallbladder problems, or particularly lipid or cholesterol problems, it's a little bit safer to take it transdermally than it is orally. The honest truth, I don't think it's that big of a difference. Okay, so the studies do show there's a difference on paper, but in practicality, it's nice, but it's not sort of a make or break thing. So if you're on pills, you're not getting poisoned. We're not poisoning your liver. It's okay. It's safe. These are sort of theoretical things, and it's probably better to take a transdermal approach through your skin if you already have some kind of issue, but it's not mission critical either. And so ways that we supply that can get it through the skin are creams and patches. And honestly, they both work well. I've found that the cream tends to take a little bit longer to take effect than the patch, but tends to be a little bit of a gentler ride. And over time, I've found that I'm having a little bit more success with the cream than the patch. The patch tends to give you kind of an early win, but then it's sort of not as good in the long run. That's not a scientific thing. That's just sort of what I've noticed with our patients. And maybe it's not the actual patch or the cream, it's the next issue, which is the cost. So our creams are compounded in our pharmacy by our compound pharmacists according to my specifications. So I tell them what dose I want, they compound it into a cream, and they send it out. And that actually keeps costs way down. The patches are manufactured as patches, and so we have to buy them wholesale and ship them to you, and the patches are pretty expensive. And so it turns out the patch is going to be about twice as much as the cream for the same dose. So patches are pretty expensive. The patch, they both work well. I've had patients say, well, you don't seem to like patches, why do you carry them? It's like, well, because some people do. And I don't want to reflect my opinion on someone else if it's safe. So if somebody wants to do something that isn't the way I would do it, but it's a safe and effective way to do it, I'm happy to prescribe it that way. The patches have a little adhesive. They're little patches, you put it on your skin, and you leave it there and you change it twice a week. So, every 3 days or so, you will take the one patch off, put a new patch on, and you want to rotate the site on your skin because for some people that adhesive, if you keep using it at the same spot, can be irritating for the skin. Every now and then you have somebody that ends up developing a rash from the adhesive that's in the patch, and so they have to discontinue it because of that. So that's a way to help keep that from happening, is sort of rotating it around and not putting on the same piece of skin 2 times in a row. And so you basically, the advantage of the patch is you only have to deal with it twice a week. The disadvantages is, number one, because it's only twice a week, it's a little bit harder to remember than something you do every day for some people, and you have to wear a patch all the time, which for some people is a little annoying. The patch is waterproof, it's okay to swim and shower with it, but for some people, it just doesn't stick that well, and that can be a problem too. The patch works fine. I'm not a huge fan of it just because I'm kind of a cheapskate. I go to Costco and buy stuff there, and the patch is pretty expensive. So for me, it's like, gosh, I wouldn't want to spend that much money for something when you can use a cream that works just as well. But it's fine, and so that's sort of the big downside of the patch. The cream is the other advantage of the cream is we can put estrogen and progesterone in the cream, whereas the patch only has estrogen. So if you need progesterone and you're on the patch, you're going to have to take a progesterone pill along with the patch, which of course increases the cost more. The cream, we can put estrogen and progesterone in the cream for the same price. Believe it or not, it's actually the cream that costs all the money. It's not the drugs, which was it's kind of news to me when I started doing this. But and so we basically can put the medicine in the cream. We can put them in together. It's a little teeny amount of cream, and you just rub it in your skin each night, and that's it. So the disadvantage is you have to remember to do it every night. The advantage is it's a lot less expensive, and you don't have to sort of wear something around all the time. The cream absorbs into your skin pretty rapidly, so some people get worried that they're going to rub on their husband or their partner and get the estrogen on them. That doesn't really happen. So you kind of rub it in at bedtime as part of your skin routine, and it's pretty much gone by the time you might be cuddling or what have you, and nothing to worry about. So that's the way the cream works. Both of those are the transdermal that avoid that first pass metabolism, a little bit safer again, but not a huge deal. The pills are pills, and I think we're pretty familiar with those. And so we have estrogen pills, progesterone are capsules, and the DHEA are capsules. Except for the capsules, everything we have is vegan. Capsules are made out of gelatin, so those aren't vegan if that's important to you, just so you know. And the pills you just take daily, just like you would any other pill, and they work quite well also. For people that have problems with nausea with estrogen, they're probably better off with the transdermal because it's not going straight to the stomach. But honestly, it's a pretty small dose, and most people really don't have problems taking these pills. So that's kind of the pills, patch, and cream thing. And again, they all work well. They all take care of your menopause symptoms. It really kind of comes down to your preference of how would you like to get the medicine into your body, and cost point. The pills and the cream are fairly equivalent in cost compared to the patch, which again is about twice as much.
The next question is from Catherine. Why is this able to be OTC?
It is not OTC. So actually, the DHEA technically is OTC. We just work it as a prescription because I think it's safer that way. Like we talked about at the very beginning, I don't want someone taking a bunch of DHEA I don't know about, and then I'm giving them estrogen, and then they end up with too much estrogen. So we treat the DHEA like a prescription, basically just to keep it safer. But I'm a licensed physician, and so and our pharmacy is a licensed pharmacy. These are real prescriptions, and gosh, I wish it was over the counter. Believe me, it's a real pain in the neck to go through all the things we have to do to keep all the various state governments happy. And the reason that our expansion is a little bit slow is, we've got to get licensed physicians in those states. We've got to get the pharmacy licensed in the states. And we go through all the regulatory process, and we're very careful to do this correctly. And these are prescription medications. So I think the telehealth thing is fairly new. COVID it was happening before COVID, but COVID really brought this out, and people realized, not only how important this was, particularly for COVID times, but how nice it is to do medicine this way. But I don't think we're all totally have our heads wrapped around what telemedicine is and, what we're actually doing. And so in a very real way, when you come on Winona and fill out the form and I accept you as a patient, we now have a doctor-patient relationship that's just as real as if I saw you in my office. And so the adaptive interview we do, where we ask you all those questions, the back and forth with the messages that we do when necessary, it's all part of that doctor-patient relationship, and it's just same standard as if I saw you in my office. When I send the prescription to the pharmacy, those are e-scripts. We go through the sort of big national e-script software, and it goes to the pharmacy as an e-script, just like your doctor would do. Nowadays, in fact, in California, it's illegal to not use e-scripts except for very specific things. And so if you went to your doctor and they prescribed you HRT, they put it in the computer and it would go to the pharmacy just like my prescription does. We keep, try and make it convenient so you don't have to drive to the pharmacy and pick this up. We just mail it to you. But this is the same thing as a doctor's visit. And these are prescription medicines. I'm a real doctor, and these are real doctor visits.
Allison says, thank you so much for answering my question. Thank you for joining us, Allison. Deneen says, years ago, I was prescribed DHEA in cream form. What is the difference between taking it in these two formats?
So this was a big disappointment for us, actually. Our compounding pharmacists are awesome. These guys are some of and gals are some of the smartest people I've worked with. And they tell me that the DHEA doesn't get absorbed well through the skin. They say, yeah, we sell it because people want it, and doctors prescribe it. But they say it's mostly a placebo. It doesn't really work well through the skin, because we were hoping we could just add it to the cream, and so you could have your estrogen, progesterone, and DHEA cream, and it'd be much simpler for you. But the compound pharmacists tell me it doesn't really work well that way, and so I trust them. And so we're not going to give you something that's a placebo. We're not going to give you something that's not going to work. And so that's why we only prescribe the oral form of the DHEA. We know it's less convenient. I wish there was a way to give it to you through a cream that actually worked and gave you drug levels. But according to our pharmacists, it just doesn't work well that way. And so that's why we use the pill form.
Catherine asks, does HRT increase the chance of breast cancer?
Great question. And that's sort of the $100,000 question, or whatever that show was. The short answer is maybe, and if so, a little bit. And so there's some big studies out there that are, not very clear. So the Women's Health Initiative study, which is the biggest HRT study, and honestly had some huge flaws in it. But even in that study, the wing where the women were just getting estrogen did not have an increased risk of breast cancer. For some reason, the women that got estrogen and progesterone had a very slight increased risk of breast cancer. There's been some other studies that also show a slight increased risk of breast cancer over time with HRT, but actually fairly small. The interesting thing is that there are other cancers that clearly have decreased risk when you take HRT, such as uterine cancer when it's prescribed correctly. We think colon cancer has a decreased risk of HRT, and other cancers as well. Also, if you start HRT before you're 60, you have a decreased risk of cardiovascular events, heart attack, stroke, that kind of thing. And so when you weigh all of this out, if you start HRT before 60 and you're a well-screened patient, which is why we ask you all those questions, you actually have a longer life expectancy than if you never took HRT at all. So people that take HRT live longer, and because they're getting all the symptom relief, they live better, healthier lives. Does it increase the risk of breast cancer? Maybe, but if so, very small. And the benefits of long life and healthy life outweigh that small risk of breast cancer. This is kind of, I don't know, some people don't like when I say this, but if you can think of one truth that every person on earth would agree with, is that everybody has to die at least once. Okay. So, unfortunately, we don't really get to choose the way we die. But what we want to do is live the best, healthiest, longest life we can. And in a well-screened patient starting before 60, HRT helps increase that longevity and also the quality of the years that you have. But I do understand the breast cancer scare. Interestingly, several large studies show that a family history of breast cancer is not enough to worry about, and it's still safe to take HRT even with a family history of breast cancer. I get that question quite a bit. Honestly, I was surprised when I saw that data, but when two really large studies came out saying the same thing, it's like, okay, well, this must be the case, even though it's not what I would have thought. And so, we hear this a lot, follow the science, but it's really true. And you get these studies, and one of the things they train us in medical school is how to read studies. Is this a good study? Is this a bad study? What are the flaws of the study? Does the study relate to my population? And so when you see two large, well-done studies that relate to your population that tell you the same thing, that is that a family history of breast cancer is not a reason to withhold hormone replacement therapy for someone, that's really what the truth must be.
Our next question is from Rasima. Sorry if I mispronounced your name. Can someone start HRT even a year after they've stopped having their period, and will it bring them back?
So the answer is yes, that's safe to do, assuming you're under 60. So 60 is sort of this big cutoff age, and it has to do with the cardiovascular effects of HRT. But so even if you haven't had your period for a while, and really the studies say 10 years, so you could be 10 years out from menopause, under 60, and it would still be safe to start hormone replacement therapy. Will it restart your periods? Most of the time, no. Occasionally, yes. My experience is that first cycle, that first month or two, that's when you sometimes see a period, and then usually they go away after that. So you kind of have to get through that. But for most people, they really don't get a period, but some people occasionally do, but usually just at the start, and then it goes away again.
Okay, our next question is from Michelle. If I start HRT and then decide to stop, are there any safety risks? Go ahead, drink the water.
Sorry. So the short answer is no, that's totally safe to do. The only thing you might get, sometimes the sudden withdrawal of the hormone can trigger a period. So if you're on HRT and you decide to stop it, it's possible you may get a period within a week or so of stopping the HRT. It's not dangerous, but just so you know, that might happen. But no, that's perfectly safe. And it's not the kind of thing that you need to wean yourself off. You can stop it all at once, abruptly, if you want to or need to.
Okay, the next question is from Angela. How do the hormones in HRT differ from birth control pills?
Great question. So, number one, birth control pills are a much higher dose of hormone because they have a totally different goal in mind. So the goal of birth control pills is to overwhelm the ovary and basically shut the ovary down so that it won't ovulate. And they do that by giving you a fairly large dose. Even the low dose birth control pills are a fairly large dose of estrogen and progesterone because they need to overwhelm the ovary so that they don't get the feedback loop to produce more hormone and, most importantly, to ovulate and make eggs. That's how birth control pills work. Hormone replacement therapy is a completely different concept. Hormone replacement therapy is just a small dose of hormone to replace what the ovary isn't making anymore. We don't want to shut your ovary down. We're happy to use the hormones that the ovaries are making. We just want to come alongside it and help it out and replace the hormones that it's not able to make anymore. And that's why I always warn people, hey, this is not birth control. And so if you're of an age that you could still be fertile, hormone replacement therapy is not birth control, and you still can get pregnant while taking it. It's a really different concept than birth control pills. So they're really different medicines. So that's the first thing, is the dosage is very different because the goals are very different. And the hormone replacement therapy is a very different dose than what's in birth control pills. The other thing about birth control pills is they use synthetic hormones. Most of them use the same estrogen, which is a synthetic estrogen. But there's a myriad of different progesterones that are used in different birth control pills, and each drug company tries to claim that their progesterone is the safest and has the least side effects. But the truth is, none of them are bioidentical. They're not the same hormones that your ovary produces, because they don't need to be. Because the goal isn't to help the ovary out, the goal is to shut the ovary down. And so these are potent hormones that are synthetic. They have their molecular structure, their biochemistry is different than the native hormones that your ovaries make. And because of that, they all have some different side effects. Progesterones in particular have, subtle different side effects depending on which progesterone you're using. And the drug companies that make the different pills, they all try and say that this is the best for this reason or that reason, and they tweak their synthetic hormones in different ways to try to change the side effects. Not all hormone replacement therapy is alike, but all Winona hormone replacement therapy is alike. So we use just bioidentical hormones. So the hormones that we use are exactly the same as the hormones that your ovary produces. Biochemically, molecularly, you can't tell the difference. If they were a big thing and you laid them down and you tried to play that, find the 10 differences between these two things, you wouldn't find any because they're identical. Okay, and so these act exactly the same way as your native hormones, as the hormones that the ovaries normally make. So they have less side effects than the birth control pills, but more importantly, they push different buttons. And so they give you benefits that birth control pills won't give you. So I have a lot of patients that are on birth control pills, but they're still experiencing these perimenopause symptoms because the hormones in the birth control pills don't push the same buttons. They don't react the same way. They don't make the body respond the same way that bioidentical natural hormones do. Even though they're on this huge chunk of estrogen and progesterone from the birth control pills, we come in with a much smaller dose of a bioidentical hormone that do push the correct buttons, and it can help these symptoms of menopause. There's a lot of misinformation about this in the medical world, and I can tell you years ago, before I really understood, honestly, bioidenticals, I was practicing before they were really available. And so, our HRT was synthetic and didn't work that great. I mean, it worked okay. But so we would use birth control pills, low-dose birth control pills, and say, you get a 2-for-1, you're not going to get pregnant, and it'll help. And it would help some of their symptoms, but not like the bioidenticals do. So now that we have bioidentical hormones, you can use that with birth control pills, and you get a lot of benefit out of them that the birth control pills won't give. I think I digressed, but did I answer the question? Yes, I did. Okay.
Yeah, you're good. So the next question.
I realized I went down a bit of a rabbit trail. Sorry about that.
Oh, no worries. The next question is Dolores. Is there a preferred time of day to do cream and DHEA?
So the DHEA can be taken any time of day. And my advice is take it whenever you're going to be able to remember it best. So if you put it with your cream and you're going to remember it best when you use your cream and you can do them together because you're doing the HRT thing, that's a great time to do it. If you're going to be better off putting it with your toothbrush and doing it in the morning when you brush your teeth, do it that way. So, consistency is important. Not necessarily consistency of time of day, but taking it every day. So the DHA is pretty easy. You can take it anytime you want, without food, with food, without food, morning, afternoon, evening, it doesn't really matter. And so that sort of opens up your possibilities with DHA. The cream is different. For most women, the hormones in the cream can be somewhat sedating, and that can be beneficial. So if you take that at night, it helps you fall asleep and helps you stay asleep, and it can really improve your sleep quality. And that is part of what gives you some of the increased energy is because you're sleeping better. So for most women, the cream works best if you use it at night. There's a small percentage of women, not insignificant, where for some reason it acts the exact opposite. And so it activates like caffeine almost rather than put people to sleep. So if you find that you're taking it in the evening and you're up all night and your mind is racing and you can't get to sleep, you may be one of those people that has the opposite effect of most people. In that case, you want to take it in the morning and put that activation to use. It's kind of like when my oldest was 4, well, not even that, he was like 3.5. Anyway, we went on a mission trip to Zimbabwe. I spent a month doing medicine there, and we stayed in this little compound, but we took him with us. And so, we thought we were smart. We got on this airplane, this like horrendous flight, as a toddler, and we gave him a Benadryl to try and knock him out. Well, we were dumb because we didn't try it at home first, and it activated him rather than put him to sleep, and it was a nightmare. So, everyone responds differently. Most people, the hormones in the cream is sedating, and so taking it at night is great, but every now and then you have somebody that it activates them, and then you want to take it in the morning. It's okay to experiment around with this and try it at different times of the day and see what works best for your body, because everybody's individual and everybody responds uniquely to these medications.
Okay, the next question has 2 parts. So what are the first steps to getting started on HRT? My PCP doesn't really think my hormones are out of whack. Should I demand a specific blood panel?
So I'm not a big believer in blood tests for HRT. I never used them in my office because you don't need them. What you really need to do is talk to the patient and see what they're experiencing. And again, HRT is really based on symptoms because that's what we're treating. So I have not found that a blood panel is useful, especially if you're already on HRT, because the HRT is going to affect the blood panel. So I'm not a big fan of it. If somebody gets a blood panel, I'm happy to look at it for them and interpret it as best I can. But blood panels aren't really useful. And I have a lot of patients who, in a situation like you, and their PCP ordered a blood panel. The blood panel didn't really say they were low. We gave them HRT, and they feel 100% better. And that's really what it's all about, is getting you feeling better and getting your symptoms under control. So if you have symptoms of perimenopause, then I think it's worth trying the hormones and seeing how you feel. If all of a sudden you take them and, a month or 2 goes by and it's like, man, I feel like $1 million. Hey, we've done the right thing. If 3 months go by and it's not really helping, we might try increasing the dose and seeing with the dose issue. If that still doesn't work, then maybe it's something else. Maybe it's something in your life. But our success rate is pretty high, and I think we have a pretty good thing going. Where we're doing a good job of identifying people that have symptoms that can be improved with hormone replacement therapy. And most of our patients, feel better and improve with the medication. And to me, that's a whole lot better than a blood test. So the process basically is you go online and start an account. There'll be a series of questions that we'll ask you. And if you I always joke, as you survive the questions, then that means you're a good candidate for hormone replacement therapy. So if we find something that makes hormone replacement therapy dangerous, or something that you shouldn't take, then we're going to stop the process and say, hey, sorry, but with this or this, it's really not safe for you to take hormone replacement therapy. My first responsibility is to keep you healthy, and I take that very seriously. So I'm not going to give you medicine that I think is going to harm you. And so we're really careful about that and making sure that the safety is there. So that's sort of the first thing. We'll also ask what your symptoms are. So I know, well, geez, what are we treating? Does it sound like something that needs some estrogen or progesterone or testosterone? And if so, then I think I can help you. Then we'll show you, I have an algorithm that I've built that works quite well, that comes up with a medication plan, and we'll ask you, what do you prefer? Would you rather use a patch? Would you rather use a cream? Would you rather use pills? And then we'll show you from the algorithm kind of what's recommended. You can decide if you like that, or no, I'd rather have pills, or what have you. And then we also show you, would you like to get this monthly or every 3 months? We show you what the prices are. And then if you decide that that's what you want to do, you say, yeah, let's go forward. We then ask you to upload your driver's license and a selfie, because that's one of the requirements of both pharmacists for the state, both for physicians and pharmacies. We have to prove you're you, and make sure that we know who we're talking to. And so we have you upload those, because again, we're careful to go through all the regulatory things and do this correctly. And then you upload a credit card. That then gets sent to me or one of my colleagues. We look over everything, make sure there's no mistakes, make sure it really is safe, and make sure we really think this is going to work. If you have questions, there's a place where you can ask us questions. We'll answer those. If you don't really have questions, and we look at it and say, yeah, this looks like it's going to be great for you, we'll go ahead and prescribe at that point. We'll send you instructions. At any time, you can message me or I can message you. We can talk back and forth through the messaging platform and see, debug things or figure out, if the dosage is wrong or what have you. Generally, there'll be a follow-up in 2 weeks to make sure, you kind of got the medicine, you figured out how to use it. Don't really expect any changes at the 2-week point, but just to touch bases with you. It's at the 3-month point that it's really important, because by 3 months I expect to really get some benefit out of this. And now we should know whether we've got the right dose. So we'll ask you again a series of questions at 3 months to see how you're doing. If you're happy, like this is great, then I'll go ahead and write a prescription that will refill automatically so that you'll get a year of medicine, and then we touch bases again every year. And I've designed this the same way that we do it in the office. So if you were in my office, we basically go through the same process. You'd come in, you tell me what your symptoms are. I'd say, gee, it looks like HRT is the right thing. I'd ask you a bunch of questions to make sure it's safe for you. Once we determine that in the office, it's the same thing, right? We talk about what prescription you want, write the prescription. I'd have you come back at 3 months to make sure everything's okay, and then I'd write you prescriptions for every year. So I really designed this to be the same way I practice medicine in my office, because again, telehealth is really the same as office medicine. It's just we're doing it in a more convenient way for both of us.
Okay, the next question is, my PCP took me off progesterone and my menopause symptoms really kicked in, including weight gain. They said being in BC has a risk of stroke. I'm now looking into this. What's the difference?
They say being in what? I'm sorry.
BC.
Birth control pills?
I'm
Probably birth control. Okay, so low estrogen, again, is a birth control pill. It's a much higher dose of estrogen and progesterone, like we talked about, because it's overwhelming the ovary. It's also a synthetic hormone, so it's not a bioidentical, so it doesn't work as well as bioidenticals work. Doesn't mean you don't get any effect from it, and so it was probably helping some of your menopause symptoms. And when they took you off of it, now your estrogen levels fell, and even though they weren't bioidentical, they were helping some, and now they're gone, and now you're feeling all these symptoms of menopause. So we can come in with the bioidentical hormones. It'll be a much lower dose, which will be safer for you. Birth control pills do have a risk of stroke, pretty small, quite honestly. HRT, theoretically has an increased risk of stroke, but again, if you start it before 60, your overall life expectancy is going to be higher than if you're never on it at all. So it's a very safe way to go, and if you don't need contraception, it makes sense to stop the birth control and start you on HRT, because we can do it with a lot less medicine and do it a whole lot safer.
Next question is, shouldn't someone have their hormone levels checked before starting HRT?
So again, the answer is no, and that's the same way I practice in my office. Hormone replacement therapy is really based on symptoms, and what are your symptoms? Sort of the analogy I made with blood pressure medicine. You wouldn't expect somebody to run a blood pressure medicine panel or even follow your dose by checking the levels of your blood pressure medicine. You do it by checking your symptoms, which in blood pressure is high blood pressure. In hormone replacement therapy, the symptoms are the symptoms of menopause transition. And so if you have these symptoms, these cluster of symptoms that are clearly from low levels of hormone, the treatment is to increase your hormone. So the way I was trained and the way I do things is I always ask myself before I order a test, what am I going to do if the test is positive? What I'm going to do if the test is negative? If the answer is the same, why am I ordering the test? And so hormone levels don't really tell us much. They don't tell us anything compared to what your symptoms tell. Your body is a much better assay of what's going on with your hormones than any lab test is. So for me, hormone replacement therapy is a waste of money. There is a whole industry out there making a lot of money off of lab tests, and some of those lab tests are really valid, but the hormone replacement therapy lab tests, quite frankly, are a waste of money. They're not helpful, they're not necessary. and they don't really contribute into the treatment. The treatment's really a symptom-based treatment. We're treating those symptoms, and we're getting those symptoms under control, and that's how we know the medicine's working.
Next question is from Eileen, and I think we've answered this one before, so you can have a brief little answer to this one. I started HRT in November, and I haven't had my monthly since November, which I'm fine with, but prior to I used to get it regularly. Is this a normal response to HRT?
It can be a normal response to HRT. More likely, it's a normal response to the menopause transition. So it's quite possible that you're sort of at that time when your periods are starting to space out anyway because of the low hormones. It's quite possible the HRT is helping stabilize your uterus that way, but it may just be sort of the natural progression of the menopause transition. Eventually, we know the periods are going to stop, and they usually will sort of space out like that before that happens. So it's hard to say whether it's really from an HRT or it's from just the natural process in your body, but either way, it sounds like a very safe thing that's going on.
The next question from Jennifer, I just started using the estrogen cream and DHEA, just wondering how you choose someone using just estrogen versus estrogen and progesterone.
So that's a great question. If you have a uterus, you need progesterone. So if you have not had a hysterectomy, if you haven't had your uterus surgically removed, you need progesterone because the estrogen by itself can stimulate the inside lining of the uterus called the endometrium, and that can cause problems for you. When we combine the estrogen and the progesterone keeps that under control and actually decreases the risk of problems compared to someone who's not on it at all. So the estrogen and progesterone are very important for women that still have a uterus. For women that don't have a uterus, the progesterone is optional. So we no longer have that absolute need for it. There are some situations where the progesterone may be beneficial. My experience is most women do well with just estrogen if they don't have a uterus, but some women we end up needing to add progesterone to get them the benefits they need. As I said before, my philosophy is that the least medicine required to relieve your symptoms is the safest way to go. And so I usually like to try with just estrogen first and see if that works. If it does, great. We saved you having to take another medicine. If it doesn't, then we add the progesterone to get that symptom control. So that's my philosophy. Now, sometimes women will say, you know what, can't we just start with progesterone? And I'm like, if that's what you want to do, I'm happy to do that. Again, if something's safe and may work, and it comes down more to philosophy, I'm happy to do what the patient wants to do, again, as long as it's safe and reasonable. And so, it's a reasonable approach to start someone directly on estrogen progesterone that doesn't have a uterus. But in general, I usually go the other route and start just estrogen. So again, the break point is going to be whether or not you've had a hysterectomy.
Okay. Next question is from Jerry. How long can one take HRT, and how do you know when to stop? Also, why DHEA? Why is DHEA recommended?
So HRT can be used as long as necessary to control your symptoms. For most women, eventually they won't need it anymore. But for some women, they need it for a long time or indefinitely. I generally recommend after 3 to 5 years, stop it for a while. Go off the medicine for a month or so and see how you feel. If you're miserable, then let's start the medicine back up and get you feeling good. If you don't feel any different, then you don't need it anymore. Again, you want to use the least amount of medicine necessary to control your symptoms. So, it's a little experiment. And again, someone asked earlier, is it risky to stop hormones right away? And it's not. And so you can do that little test every now and then. Stop the hormones for a month, see how you feel. If your body will let you know whether it was something that you needed or not. And if you find that you don't feel any different, then it's probably not necessary anymore. So after a few years, that's a reasonable thing to do. And then let's say that it's like, oh no, I still need it. Well, then wait a couple more years and try again, or however long that you decide that you want to wait. Don't stop medicine just before some important thing in case you don't feel well. So choose your timing, sometime where things are going to be easy and relaxed. And so if all the symptoms come back, it's not going to mess something up for you. Don't do it just before you go on vacation or something. But that's basically how you do it. It's a little test and see what your body needs. There was a second part to the question. Why is DHEA recommended? I kind of talked about this before, but DHEA gets broken down into estrogen and testosterone. And it's a really safe, easy way of getting your testosterone levels up to normal levels, normal youthful levels, without overshooting. So with 25 to 50 milligrams of DHEA daily, it's pretty much impossible to overshoot and get your testosterone levels too high. But that does generally get you kind of right smack where you're supposed to be. So it's a nice, easy, safe, gentle way of getting your testosterone levels up. And testosterone can be very important for women. I know we think of it as a male hormone, but women's testosterone levels also drop over time. At 50, the average woman, her testosterone levels are about 50% of what they were when she was 30. And testosterone can be really important. It can help with weight. It can help with not just weight, but muscle mass and where that weight is. So you can go from an hourglass shape to a pear shape or an apple shape pretty quickly, and have all that weight move into your torso and your belly and in your viscera inside. And the testosterone helps move that back to where it's supposed to. It also helps increase lean muscle mass. So your muscles improve without all the fat. And so it's really healthy for you. It also increases libido, which is another issue that people have during the menopause transition. And it can also help with energy levels. So testosterone does have a lot of important effects, and the DHEA is a nice way of getting the testosterone level to where you want it.
Okay, one of our last questions is from Winona. What would be the reasons for water gain when starting with HRT?
So yeah, one of the things that that hormones can do when they change rapidly is make you retain water, and women see that you already know this from your lifelong experience with your periods. So a lot of women around the changes in the menstrual cycle will get bloating, and they'll put on water weight, and then that will shed once the hormones get back to normal. And that's the same thing with HRT. Again, because we're starting and we're getting sort of a rapid change in drug level of your hormone levels, that can cause water weight, weight retention, some bloating. It usually goes away pretty quickly as the body gets used to the medication, and you get a nice steady dose, a nice steady state of the medication. Generally that water weight will go away and the bloating will go away. But that is something that does happen.
So that looks like it was our last question. The rest of them are thanking you, Dr. Green. So Roxana says thank you, Shauna, Jennifer, Jerry. I really appreciate this telemed. Thank you all for being here, and thank you, Dr. Green, for answering all these great questions.
No, it's my pleasure. I mean, I see my job primarily as an educator. There's a lot of ways to do things, and I want to educate you about options, and then you got to decide what's best for your body, and you can't do that without all the information. So it's my pleasure to be able to provide that for you. And thanks for showing up.
Yeah, thank you for showing up, and always reach out if you have any questions.
Yeah, please don't be hesitant to message me or whoever your doctor is on the Winona platform. We're very happy to answer your questions. We want you healthy and happy and feeling your best.
Awesome. Well, I hope everyone has a good evening, and we'll see you on the next webinar. If you want to sign up, we have another one in March.
See you then.
Thank you, everyone. Bye.
All right. Bye.